last question.
Yes.
Yes.
It's not just a question. I'm an infertility specialist and I'm treating patients with male infertility problems also. I want to bring to notice of everybody that we are not supposed to treat the testosterone deficiency. Once you see that low testosterone level, one test which I want everybody to do is serum FSH. Try and understand there are two types of hypogonadism. One is hypogonadotrophic hypogonadism and other is hypergonadotropic hypogonadism. If I just want to make the hypothalamo-pituitary testicular axis to you, here the FSH and LH are produced, which is going to act on the testicles. The LH is going to produce testosterone and the FSH has its role in producing spermatogenesis, right? Suppose somebody is not having hormones from here, testes will not get a stimulus and there won't be testosterone. Now, if you give this patient testosterone therapy, or as it is happening so commonly in gyms and people who are taking testicular replacement therapies, there will be a feedback stimulation and the LH and FSH are also going to decrease more. So, once you see the symptoms of testicular deficiency, get a serum FSH done. If the serum FSH is less than 1, we usually quote hypogonadotrophic hypogonadism as less than 1, but anywhere like 2 also is also not that good. So now how are you going to treat this patient? You are going to give HCG for 3 months. This is going, what does HCG do? HCG is like mimics the action of LH. So it's going to build up the testicle volume. It's not going to produce sperms. It's going to build up the testicular volume. And after 3 months of HCG, then we give HMG. HMG has got LH component as well as FSH components. I have seen people who have got no sperms, but you have to be patient. After 3 months of HMG, you will start seeing sperms. Some people do produce a baby spontaneously, some people require. Now, the second component is hypergonadotrophic hypogonadism. Matlab, hormones are also not normal here. Hormones are also not normal here, but the testicles are not functioning. So now the testicles are not functioning, so there is no testosterone. As there is no testosterone, there is a feedback stimulation, there is no testosterone. So the FSH goes to a very high range because your hypothalamic and pituitary is trying to combat it. So here, the FSH is more than 15. Any male whose FSH is more than 15, I call that this patient will require sperms from outside. So here, yes, this is the point where you can give testicular replacement therapy for his own benefit. This is not going to produce sperms, but it will make him, slightly more masculine. And
Thank you.
Thank you.
Thank you, Dr. Patil. It was a wonderful presentation, and I think everybody here are charged up after your testicular replacement therapy.
Thank you very much.
Usually the dose of HCG in males is 1000 or 2000 IU. Now, what I use in my practice is 5000 IU. I am belonging to a country which is not so rich. So what I do is, I dilute that. Because people, pharmaceutical company will tell you that no, don't use it, it gets spoiled, something, nothing happens. Nothing happens. I use a 5000 wala injection, I dilute it into 2 and then I give it on Wednesday, Sunday. Or the other schedule is 1000 you can give alternate day. You have to give it for 3 months. After 3 months, when you start the patient on HMG, 75 IU Wednesday, Sunday. But again, the cheaper injection is 150. I mean, if you go and buy a 75 mg injection, it is much more expensive. Or थोड़े से expensive में 150 मिलता है. So I dilute 150 mg injection. I tell the patient 1 ml on Wednesday, 1 ml on Sunday. That's my schedule. Yes. But then those are more expensive. I am staying in a place which cannot afford. We are not in Mumbai where the IVF cycles are so expensive. Some of my patients are very poor, so we know how to save the cost. Sirsa, yes, I belong to Sirsa.
HMG also another 3 months.
At least, look, any male therapy, we have to understand that sperms which are produced today are going to come out after 64 days. So any form of male therapy has to be given for 2.5 months before you actually check that it's good or bad.
From 72 to 90 days.
Okay, so 3 months, yes.
And which testosterone preparation is
I also use testosterone in ladies patients with poor ovarian reserve. Those patients who cannot produce their eggs or nearing 40, but they are very adamant on producing their own sperms, the testosterone gel, it is very free, yeah. So, yeah. Intas. So it comes, वही वाली बात है कि एक one puff, fixed dose. So we give the female in -1 cycle. मतलब the cycle we want to stimulate her, we start her 1 to 2 cycles before. It brings up your, whatever the remaining follicles are there, it brings up. I'm telling, I use testosterone gels in people who have got very low reserve of eggs. If I'm talking about the females, it brings, like, you know what, the DHA he'd mentioned. DHA is also got the little bit of male, this thing. One study was done, it was 10 years back, that a patient could not produce her own eggs in IVF cycle, 1 cycle, 2 cycle. So she was given this DHA. DHA, after 2 years, she could produce her own eggs. So we started using DHA for the same purpose why we are using the testosterone gel. We start using it in -1 cycle or maybe 2 cycles prior, and she produces more eggs.
No, but that is okay, but what is the mechanism behind it? But how it acts?
Somehow the testosterone has a role in recruiting those left out eggs. The little bit, like, you know what, a patient of 40 years will not probably have a menopause till 45 years. So that means she has some eggs which will come out after 2-3 months. So by using that testosterone gel, we are, taking out all of them for our IVF sake.
And in other words, the logic is not like that. The logic
Okay.
is that we give the small quantity of testosterone in the ladies that suppresses the production of FSH and LH
Okay.
and the higher level. And these ladies who are at a menopausal, premenopausal age, they had a very low, high FSH levels. We want to suppress that FSH level
Okay.
so that the ovary can again reproduce. the
Or
eggs
we
and
want
all.
to suppress any FSH or LH level when we are doing an IVF cycle.
yeah.
So probably that can just add.
And I also want to highlight one thing. You have to see the purpose. What is the purpose of using all this hormonal therapy? Whether you want to do the improve the spermatogenesis, then GnRH analog that used to be used, means you have to do the FHs. But if your purpose is to increase the libido or the erectile dysfunction, then testosterone is the choice.
Yes.
But you have to be very cautious while giving the testosterone when the patient is at a puberty age, because otherwise the bones will stop growing and he will be very dwarf. So that is the basic logic.
DHA should not be given because these PCOD patients, you have to screen it. PCOD patients, we should not do.
DHA, yes.
What about hypoactive sexual desire disorder in postmenopausal women? Have
last
you any experience
question,
about
please.
that? Because I have mentioned that is one of the indications.
I have not done. Yeah, she can throw light on it. But yes, I was also thinking during this conference, I was thinking that how should I, so maybe adding a little bit of testosterone or.
Thank you, madam. Thank you.
Thank you so much.